Hello, friends. This is Grand Test discussion of endodontics and conservative dentistry. I'm Dr. Aishvarya Kaushik. Your first question that I put was power bleaching. Power bleaching employs. Now we have a few options, and then I've expected you to know the more than one correct answer. So, first of all, the correct answer is power bleaching employs either a laser or a xenon plasma curing light. All right. So, xenon plasma curing, that's option 2 and 3 are correct. So the answer is B, either 2 or 3. Why have I put this question? Well, for the simple reason that these days aesthetics and bleaching is pretty important. People are asking questions, especially AIMS, INI, even in NEET, the method of choice of bleaching in case of tetracycline stains, microabrasion, macroabrasion, after how much time of bleaching should you um, do your permanent composite restoration, so on and so forth. So, n number of questions, small chapter, but at least 10, 12 MCQs are coming these days. So, that is the idea. I want you to stay connected with this small, short topic of bleaching, but at the same time, a lot of overlapping concepts. So, that's why I put this relatively new question from the latest edition of Cohen. There's another reason why I put this question. There is this misconception amongst many of us rather, that power bleaching basically is synonymous with zoom bleaching. Friends, zoom bleaching is separate. It's basically nothing but blue LED light only. In zoom, you're practically using blue LED light only. So it's you can say a much more advanced version of your normal LED light that you're using in your clinic. Philips zoom LED light is slightly more intense, but the wavelength is that of blue, right? So zoom bleaching is not power bleaching. Power bleaching specifically is either laser that's providing you with a lot of heat. So that's one thing. So it's either laser, right? Or it's your plasma arc curing light. So they provide you with pretty high intense, you can say, activation of your bleaching agent, and the bleaching agent used is normal, which you're using in routine in office vital bleaching procedures like 30 to 35% hydrogen peroxide. So that's normal, right? But it's just that you're activating it further. Instead of routine blue light, you're activating it further with either a laser or plasma curing. Right, friends? This takes me to the next question. What is this wavelength of light that is used uh, when you're using lasers as part of your power bleaching protocol? And the answer is you can use either 830 nanometer or 980 nanometer, right? So that's again a direct pick from your standard textbook Cohen. So the answer is A. This brings me to the next important point. When you simply use, this is a separate point, so don't get confused here. Separate point when you're very important, I'll star mark this, a very important favorite MCQ is in routine LED or blue light bleaching, which is actually nothing but zoom, or if you're not rich enough to buy that specific Philips zoom apparatus, your simple LED light. That LED light is what kind of light? Is it hot or is it cold? It's a cold. It's a cold blue light, right? And the wavelength is roughly around 465 nanometer. And that is pretty common sense because your LED light in general, if you read your Studevant, it's written around 470, 468 nanometers. If you read your Philips, it's in the range of 470 to 480 nanometers. And in Cohen, it writes 465 nanometers. So it's basically blue region. But what is more important is cold. It's a cold blue light. Again, a lot of misconception and confusion going on here also, because people think that you're providing extra source of heat in the form of blue light, so probably it's hot, the light is hot. No, it's not, right? It's a cold blue light. The wavelength is in the range of 460 to 480 nanometers. Cohen specifically writes 465 nanometers, so that's also correct. If somewhere you get in the range of 468 nanometers, that's also correct, right? Someone asks you what is the wavelength of light of zoom, specifically zoom, that's also in this range, 460, 470, 480, up to 500. So it's basically in this range only, right? It's basically blue light, cold blue light. But that's not the case with laser. Laser is separate. Laser wavelength is separate. That's 830 or 980 nanometers. So that's somewhere in rather in the infrared range, right? And that's actually providing you with heat, right? Okay, what is a tooth sleuth? It's a basically a pointed kind of a device, a handheld device which is having a conical end, right? Which is used to apply pressure on specific areas of the tooth. So especially in cusped teeth like premolars, molars, you can apply pressure on specific areas, all right, in order to diagnose whether that specific area of the tooth is cracked or not, whether it has a crack or a complete fracture or not. And usually what happens is, yes, there can be pain on biting, but more typically in a cracked tooth there is pain on release of pressure, right? So our answer is simple. That's, you're trying to diagnose a cracked cusp, right? Teeth that are considered more prone to developing cracks. Again, a straight pick, a new question. Straight pick. This is a new question that I basically made from Cohen. Seeing the trend, these days, direct picks from standard textbooks are coming in the form of new questions, which actually makes sense, isn't it? Giving new questions from vague articles which you are never going to read doesn't make sense. So it's practical, it's logical, and on those lines, I've made this GT paper. So teeth that are considered more prone to developing cracks. Again, this is from the chapter Cracks and Fractures. In your latest Cohen, it's a separate chapter. In previous editions, it was a part of endodontic diagnosis. That was your first chapter. So you can see the importance of this chapter here. Again, small topic, small chapter, multiple MCQs come from here. Anyways, as far as this question is concerned, it's routine clinical practice. The patient is perfectly fine, no caries. The patient has this habit of chewing on ice, isn't it? There's patients who come, I love biting on ice. I just go to my fridge, open my freezer compartment, take out ice cubes and chew on 2-3 ice cubes every day or every 5-6 hours. And you have a classic case of cracked or obvious split tooth or complete center split tooth originating on the crown surface of the tooth in maxillary premolars, very common, as well as relatively, you can say, less common, but equally important as far as Cohen is concerned, is your mandibular second molars. So when you talk of cracked cusps, tooth is perfectly fine, no history of RCT, no caries, otherwise no reason of apical periodontitis except for the fact that cracks have developed due to trauma, right? Due to excessive biting forces and habits such as biting on ice cubes. So the answer is maxillary premolars and mandibular second molars. So that's our answer here, right? The role of neodymium YAG lasers in the management of dentinal hypersensitivity is related to. Now, this is again a very controversial question, simply because there are two things which confuse us. One is, see, when I talk of laser in the management of dentinal hypersensitivity, we are looking at two things. Laser is basically a source of energy in the form of heat. So it's going to melt some portion of dentine when you apply that burst of energy, right, due to heat. And that portion is going to cause clogging or you can say, occlusion of your dentinal tubules, which is going to help in the prevention of, um, movement of dentinal fluid inside the dentinal tubules on stimulation like hot, cold, desiccation, osmotic stimuli, eating sweet and sweet foods, etc. So that's one thing, right? Because of melting and then solidification, it causes superficial occlusion of dentinal tubules. Right. The second important thing is that lasers also have been, have seen are seen to cause reduction or blockage or prevention of conduction of action potential in C fibers, or in another reference it's written in the pulp, right? Now the very important thing here to realize is, friends, that both these statements 1 and 2 are correct, right? And the examiner kind of gives you both these options, and then you're like, which one should I choose, right? Now, friends, the catch here is dentinal hypersensitivity. Dentinal hypersensitivity is basically a result of stimulation of A delta fibers, right? So, my sense says that if you have this option, which is occlusion or blockage of dentinal tubules, right, go for this in the options. If you don't have this option, then as a second best option, go for prevention of action potential in C fibers or in the pulp, right? It is a true statement, but dentinal hypersensitivity is because of nerve impulse conduction at the peripheral areas of the dentine pulp complex. And there we have A delta fibers. And the classic pain of dentinal hypersensitivity is sharp, shooting, lancinating, knife-like, of a shorter duration, signifying reversible pulpitis. If you have stimulation of C fibers, you're basically looking at a situation of deep caries and at a diagnosis of symptomatic irreversible pulpitis or asymptomatic irreversible pulpitis, whatever the case may be, right? So yes, lasers do have a role in the prevention of nerve impulse conduction in C fibers, but is that the reason that is attributed to the role of lasers in the management of dentinal hypersensitivity? No, guys, right? The better answer is occlusion or blockage of dentinal tubules, right? So my answer here is A, superficial occlusion of dentinal tubules, and up to 4 microns is obviously an added line which is there in your Cohen. So no harm in memorizing this, just in case the examiner wants to give an extremely tough question. He might be playing with this depth as well. He might give you an option which is, one is superficial occlusion of dentinal tubules up to 4 microns. Then he can say up to 10 microns, up to 18 microns, up to 20 microns. That can happen, and this kind of thing does happen in senior residency papers. And you all know a lot of repeats in your INI are coming from your SRship papers, right? As far as NEET is concerned, why not? Many a times it happens that the quality of questions in terms of uh, novelty, newness is compromised. The examiner has less time, so he simply takes some questions from NEET, some questions from previous INI, and just frames up the paper. So we have to be ready for all these things, right? Moving forward, tissue pressure in the pulp, in the normal pulp, right? So there are two things here. What is the tissue pressure in millimeters mercury? That's about 10 millimeters mercury in the normal pulp, which is equal to 14 centimeter of a column of water, right? So that's the answer for the normal pulp. And what about in case of inflammation or pulpitis, or if the examiner wants to specifically mention symptomatic irreversible pulpitis, or simply says in an inflamed pulp, then the answer goes up um, to in millimeters Hg, it's about 25 millimeters mercury, which is almost equal to a column of 35 centimeter of water, guys. Right? So these are the two things you can memorize here. So let's look at this. We have tissue pressure in the normal pulp. Now the answer is 10 mmHg. And because I want you to remember both these values, I have put a related question: tissue pressure in the pulp in acute pulpitis. Acute obviously is a word which is more commonly used by oral pathologists and less by clinicians, that is endodontists. So that's about 25 mmHg, which is approximately equal to 35 centimeter of a column of water. Typically, a tooth that responds to heat and then is relieved by cold is found to be, right? Now this tooth is typically, the answer is a necrotic tooth, friends. Typically this answer is necrotic tooth. All right. Why does this happen? Well, you have a tooth which is the patient did not seek any treatment. That's our pulp. Those deep caries. The tooth underwent asymptomatic necrosis initially, so the patient did not come. Or if the patient had pain, he took some painkillers, the acute phase ended, the patient became painless, he was avoiding treatment, not going to the doctor. And then, after a period of time, what happened was the patient is giving you now a history that, I've got severe pain on taking something hot, which is relieved by cold, right? So the answer is pulpal necrosis. And what is the reason? So necrotic tooth, guys, in a period of about 3 weeks, that is about 21 days, is colonized by bacteria, right? The bacteria is eating up food, right? It is metabolizing and it is releasing acids. Now these acids, they, on exposure to anything hot, like hot liquid, hot tea, they expand, right? And they escape into the PDL space, right? PDL is richly innervated. PDL is not necrotic usually in a case of pulpal necrosis, right? It's only the pulp that is necrotic. And then there is severe pain. So how do you relieve that pain? How does the patient relieve that pain? It is relieved by the application of cold compresses. So many a times the patient who's sitting in the OPD with a chilled jar of ice or water or an ice bag or a ice pack is sitting in your OPD against the offending tooth, or holding chilled water in that area of the mouth, right? And tilting her or his head towards that area and saying, giving you a typical history that, doctor, I have got, the only way I can relieve this pain is by doing this. That's a classic case of pulpal necrosis, or even advanced stages of irreversible pulpitis, right? So what happens is irreversible pulpitis, advanced stages, it's basically turning necrotic. Some vital pulp is left in some canal, but for all practical purposes, the tooth is necrotic. So I would say a better answer is pulpal necrosis. Yes, irreversible pulpitis also can present like this, but a better answer is pulpal necrosis. Radiographic appearance of symptomatic apical periodontitis, right? So first of all, what is symptomatic apical periodontitis, guys. It's basically, in olden terms, acute, or in oral pathology terms, acute apical periodontitis. But obviously, this is no longer the terminology that is used, right? So, right, we're no longer, the American Board of Endodontists is no longer recommending this terminology. So we're using the term symptomatic apical periodontitis, and in most simple terms, it basically implies that the tooth is, when you do percussion, thuk, 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 the tooth is tender to percussion. That's the classic clinical presentation. TOP positive, that's what we write. Tenderness on percussion, and obviously being endodontist, so tenderness on vertical percussion, that's a classical thing, is positive. The most obvious, most common reason is a sequelae to pulpal necrosis. So friends, in symptomatic apical periodontitis, which is the terminology that we're using right now, as I said, the most common reason is it's a inflammation of the periapical tissues as a sequelae to pulpal necrosis. So that's one thing. So in that case, the pulpal vitality tests would be negative, isn't it? But symptomatic apical periodontitis can also be due to malocclusion or a high point, any problem with an occlusion, with the occlusion. So high point in restoration. So in that case, the vitality test can be positive also. That's one thing. Second, the tooth is suffering from symptomatic irreversible pulpitis, right? And inflammatory mediators have gone, so the tooth is still vital, and the inflammatory mediators have egressed or have traversed the apical foramen and have caused acute inflammation in the PDL. So in that case also, the vitality tests would be positive, right? So one thing is very clear, in symptomatic apical periodontitis, vitality tests can be positive or negative, right? Next important thing, radiographic features. Now in radiographic features, again, if it's a long-standing lesion, right, then you can have a proper apical or periapical radiolucency. All right. However, you might just have simply widening of the PDL. So widening of the PDL is characterized, is kind of documented separately. It is not considered a proper periapical radiolucency, although it is, but widening of the PDL is in itself a separate entity as far as endodontic literature is concerned. So what we say is that radiographic appearance of symptomatic apical periodontitis ranges from a simple widening of the PDL to apical radiolucency. So in other words, widening of the PDL is definitely there. Apical radiolucency may or may not be there. So plus or minus, right? So that's the defining feature here. Very important, guys. Where's my highlighter? Yeah. So widening of the PDL will definitely be there. Apical radiolucency might be there, might not be there. Vitality test, again, might be positive, might be negative. Right. So what's the answer here? Radiographic appearance of symptomatic apical periodontitis. My answer here would be, will typically exhibit at least a widened PDL space, right? And may or may not show an apical radiolucency, right? So again, a very, you can say very conceptual as well as of course, concepts are developed only once you memorize things. So the first step is to read your literature well, right? Okay, the periapical lesion that would most likely contain bacteria is an abscess, all right? So an abscess usually contains bacteria. That's routine, knowledge from your oral medicine, oral surgery, oral path, and endo. So that's a direct question. Monofilament sutures are removed after. Now, again, this has been kind of some controversy. So, usually the answer is 48 to 72 hours. So, here the nearest option is 2 days here. So, I would go with 2 days, right? 48 hours. Hopefully, the examiner should not go to the extent of confusing you by giving you options like 2 days and 3 days separately. I don't think that is going to happen. If that happens, it's anybody's answer. Frankly, this is the correct. Nothing is wrong here. 2 days is also correct. 3 days is also correct. The answer is 2 to 3 days, right? After cavity prep, dentine is dried with. See, basically, it's a soft blow of air. So wherever you see soft blow of air, that's the answer. So cotton pellet with soft blow of air. Why have I put these other options, acetone, alcohol? Because everything has been tried, right? But presently, the most accepted answer is cotton pellet with soft blow of air. Which of these is a predictable landmark for working length determination, guys? Of course, is stopping at the apical constriction. And the apical constriction usually, not necessarily, but usually coincides with the cemento-dentinal junction. Now, there's a slight kind of, I would say, inherent error in the language of this question, in the sense that, I mean, cemento-dentinal junction is a histologic landmark, right? So you can't determine that as such without extracting the tooth, right? But yes, we're trying to be as close to the apical constriction as possible, which is also known as the minor constriction, right? That is an achievable goal by correlating our X-ray as well as our apex locator findings, right? And reaching a consensus that we are nearest to the apical constriction. Because apical constriction is not there in the options, and the fact that apical constriction many a times is very, very near to the CDJ, the answer is CDJ. All right. If a patient is allergic to sodium hypochlorite, which other material could the patient be allergic to? So it's basically chlorine, right? So you should not use chlorhexidine, right? Added knowledge here. According to Cohen, it writes that in this kind of case, you can irrigate. So basically, avoid sodium hypochlorite, avoid chlorhexidine, even avoid simple saline. So irrigate with distilled water, right? Because saline also has chlorine, right? So irrigate with distilled water. And then what you can do? What irrigant can you use? You can use IKI. What is that? Iodine potassium iodide. Iodine potassium iodide. So this is the next generation or next level of question that can be asked here. That in such a case where the patient, you cannot irrigate with sodium hypo, you cannot irrigate with chlorhex, you cannot irrigate with saline, what do? You simply do some mechanical lubrication with distilled water, and irrigate with iodine potassium iodide and give an intracanal medicament of calcium hydroxide, right? So rely on this protocol, right? Question is Brinell hardness number. This is relating to Brinell hardness number. So Brinell hardness number of a dental gold alloy is directly proportional to its. There are certain few important points regarding these, each and every hardness number or hardness test. Mostly the MCQs are taken directly from your standard textbook, and that's your Phillips. Completely ratification, memory-based questions. So, as far as Brinell hardness number is concerned, what are the important and salient points regarding this? And then, of course, we reach the answer. As far as Brinell hardness number is concerned, friends, it is the oldest hardness test. It is a macro hardness test. It employs a steel ball to create the indentation. Or in very simple and dental materials terminology, plastic deformation, irreversible deformation on the test material surface. What else is important regarding Brinell hardness number? It is a standard test, or it's a test which is used to test the hardness number of metals and metallic materials. So in general, if you see this term, metals or metallic materials, then your answer is Brinell hardness number. Apart from that, another important line from Phillips is it is a test which is related to. I am exactly quoting Phillips because these questions are going to come directly from here. So it's directly related to the proportional limit. Proportional limit and the ultimate tensile strength of gold alloys. So friends, when you see this, you should be in a position to answer that this is related to Brinell hardness number. So look for these two terms: proportional limit and ultimate tensile strength. So in the question, what do you have? You have Brinell hardness number of gold alloy is directly related or directly proportional to, what are the four options? Tensile strength, elongation, modulus of elasticity, modulus of resilience, right? So our answer is tensile strength, right? And more specifically or more precisely, as far as Phillips is concerned, it's ultimate tensile strength. So quickly reviewing this knowledge, if you draw a stress strain curve, that's the end of your straight line portion is your proportional limit, and the end of the graph is the ultimate tensile strength, if you're talking of tensile stress, right? So the Brinell hardness number is used to determine the ultimate tensile strength, or it's related to, not determine, but it's related to, right, the proportional limit and the ultimate tensile strength. So the answer for question number 15 is A, tensile strength. The hardness test, which is independent of ductility of a material. So in this, the answer is first of all Knoop, right guys? The answer is Knoop, without a doubt. Again, straight pick from your Phillips. One of the very favorite questions these days is the hardness test out of the first few chapters of your dental materials Phillips. That's the reason why I've put so many questions from hardness test. We want to solve them from each and every perspective, each and every angle. So Knoop test, what are the salient features, guys? Knoop hardness number or test. So the tip, it's a diamond tipped instrument which is used to diamond tipped indenter or tool which is used to create the indentation or plastic deformation. And what's the shape of the tip? It's a rhombic in shape. So it's like, right? So you have a shorter diagonal and a longer diagonal. right? So this is going to create that indentation, and this test is classically used to test the hardness of materials, various materials like brittle structure like enamel, a resilient structure like dentine, metals, metallic materials, etc., etc. Right? So, and of course, a direct line from Phillips that this test is independent of the ductility of a material. Right? So, material can be extremely ductile. It may not be that ductile. Right? What is ductile? Ductility is the plastic deformation or irreversible deformation under a tensile load. Right? I'll tell you a couple of more important points here. If I draw a stress, right, I'll do it here. I'll draw a stress strain curve here. Right. So this is the zone of plastic deformation. This material is pretty ductile, and this material is specifically fracturing here at right at the proportional limit or very near to the proportional limit, because it's you know plastic deformation area, or the extent of plastic deformation, not the area but the extent, the length of plastic deformation is very less, so it's less ductile. So you have a more ductile material in this. Let this be B, and let this material be A. So this is relatively less ductile. So the concept is that a Knoop hardness test can be used for both, right? It does not have any limitations in terms of ductility. So in other words, it can be used for brittle materials. Now there's a catch here. If specifically asked which test is used or done specifically for brittle materials, then the better answer is Vickers. You understand, guys? I'll tell you why. Simply because this is directly taken from Phillips. Now, this does not mean that you cannot do Knoop test for brittle materials. You can, because it's independent of ductility, right? But Vickers test is also a good test, rather the test of choice for brittle materials. So if you don't have both of them in the option and only one in the option, then mark whichever is there. If you have both in the options and the question is which test is a good test or the best test or the test of choice for brittle materials, and if you have both Knoop and Vickers in the option, go for Vickers. If you have specifically which test is the test of choice which is considered independent of ductility of materials, then the answer is Knoop. Right, guys? So we have the hardness test, which is independent of ductility of a material, then the answer is Knoop test. Right? Next question. For standard testing of dental casting gold alloys, which hardness test is used? Again, overlapping answer, confusing answer. You know why? Because in question number 15, I told you guys that when you talk of Brinell hardness number or Brinell hardness test or Brinell test, then it is directly related to the proportional limit and the ultimate tensile strength of gold alloys. However, the test which is considered the standard test for dental casting gold alloys is the Vickers test. You understand? So that's why the question here, for standard testing For standard testing of casting gold alloys, the hardness test that you use is Vickers, right? Since we're talking of Vickers, I've told you another important point. One is standard testing of casting gold alloys. The other is the test of choice for testing brittle materials. That's your Vickers. Then what is the shape of the tip of the tool or the indenter of the Vickers test? That is a square based pyramid. So you had a rhombic or a rhomboid shape for Knoop test, but for um, Wicker you have a square based pyramid, right? So it's something like this. All the four sides are going to be the same. So when you draw these two diagonals, they are going to be the same dimension. Whereas for Vickers, one was longer than the other, right? You had a longer diagonal and you have a shorter diagonal. Here, because it's a square based pyramid, for Vickers, you have both diagonals same or equal, right? So these are the points which have to be memorized here. Another important point, both okay, question number 18, which hardness test is used to test the ultimate tensile strength and proportional limit of gold alloys? Again, this we've discussed. This is Brinell. So this is another form in which the Brinell test can be asked to you. Okay, let's discuss the next question. That's viscosity. So we are wrapping up the hardness tests here. Couple of more important points that I wanted to tell you was, guys, you all know, like both Knoop and Wicker are micro hardness tests, right? Both Knoop and Wicker's tests are micro hardness tests, right? Now, there's this misconception that micro hardness test means they cannot be used for softer materials or very hard materials, right? That's not the point. Both Knoop and Wickers can be used for relatively soft materials also and very hard materials, metallic materials as well. Why they are known as micro hardness test is because of the force that they apply. The force that they apply is 9.8 Newton only. And the depth of indentation is less than 19 micron. And therefore, it's not the fact that they cannot be used for hard metallic materials, right? That's the misconception, right? People think that only Brinell and Rockwell can be used for metals and metallic materials and alloys. No, both Knoop and Wicker are also used to test metals and metallic materials, but the difference is that they used to do that. This load is applied on a very small surface area of a thin section of the metal or the alloy, right? So it's applied, the force is applied on a small surface area on a thin test specimen, right? So these are the three important points which are directly related to the fact that they are micro hardness tests, that the applied load is less. Obviously, because of that, the resulting indentation on a metallic material is going to be less, up to 19 micron, and they're applied, the load is applied on a small area on a thin test specimen, right? So that's the important point here. Our next question pertains to viscosity. The definition of viscosity. Now, viscosity is the, you can say, the liquid counterpart of modulus of elasticity or rigidity of a solid. So what modulus of elasticity or rigidity is to solid, viscosity is to the liquid, right? So when you talk of modulus of elasticity or the Young's modulus. This property is that for a solid, and this is the slope of the stress strain graph, right? So the slope of the stress strain graph would give you the modulus of elasticity. When you talk of viscosity, there's one very important, of course, the similarity, that it's the resistance to flow in terms of a fluid or a liquid. But the difference here is when you compare modulus of elasticity for a solid with the viscosity of a liquid, then it's the slope of the stress, shear stress strain rate. It's the rate of strain. So there's an added dimension of time, right? It's like speed, right? Because when a fluid moves, it moves with a certain speed, right? So change in length over the original length, or change in dimension over the original dimension per unit time. So it's the strain rate, right? And that's why, in order to confuse you guys, we've put the similar options of A and B: shear stress divided by strain rate, shear stress divided by strain, right? So that's very important, friends, to realize that there's one very important critical difference between Young's modulus or modulus of elasticity and viscosity, right? So when I draw the shear stress versus strain, then it's the, on the x-axis, it's the strain rate, right? So it's change in dimension over original dimension divided by the time, right? And of course, in similar fashion, like modulus of elasticity is the slope of this curve, which is going to give you the the value of viscosity. Another related MCQ that comes here is perfect straight line where the shear stress is directly proportional to the strain rate is a Newtonian liquid. Then we have another in which, as the shear stress increases, the strain rate increases but disproportionately, right? And that's a pseudoplastic. So the viscosity keeps on decreasing, or the material keeps on becoming more fluid as you keep on applying more forces, right? And the opposite is a dilatant liquid, in which when you keep on increasing the external shear force, then the viscosity keeps on increasing. The shear stress divided by strain rate slope keeps on getting more steeper. And last and equally important is your plastic material. Again, a perfect straight line, just like Newtonian, but you need certain amount of force, basic amount of force here, right? Some basic amount of force to kind of awaken that material into motion, right? So this material is like sleeping like Kumbhkarn. It's not moving, right? It's like a sauce bottle. You have to apply some basic amount of force, but once it starts moving in a perfectly proportional manner like that of a Newtonian liquid, right? So this is another very important image-based question that is there in the examinations. They give you these four graphs, they would number them 1, 2, 3, 4, or A, B, C, D, and they would expect you to know which graph represents which kind of liquid. Next question: reddish brownish hue in the Vita classical shade guide is represented by. So basically, this is about your knowledge of Vita classical shade guide, very important. So you talk of hues in the Vita classical shade guide, you basically have A, B, C, and D. That's specifically related to what color, what wavelength of color this is. So this is reddish, brownish, A. Then B is reddish, memorize this, yellowish. Then C is gray, and D is reddish, grayish. right? As far as further numbering is concerned, you have 1, 2, 3, 4. What does these represent? So it's, for example, A1, A2, A3, A4. Similar manner, B1, B2, B3, B4, and so on for C and D, right? Now, here the concept is, guys, that 1 to 4 represents, 1, 2, 3, 4 basically represents your value, right? 1 is highest value, 4 is lowest value, meaning 1 is the whitest, 4 is the blackest, in very simple terms, right? Also, equally important is chroma. 1, 2, 3, 4, the chroma increases. The degree of saturation of that particular hue increases. So in general, the so for example, if it's A, and I'm considering when I'm talking of A and I'm moving from A 1, 2, 3, 4, basically the hue remains reddish brownish, no doubt about that, right? But from 1 to A4, the value keeps on decreasing. The color keeps on getting from white to black, right, on the gray scale. And the chroma keeps on increasing because the degree of saturation of this reddish brownish color would keep on increasing. So it's going to become darker, right? Next important related MCQ is, which is the whitest out of, so from this information we know that when I talk of C1 to C4 and so on, and D2 to D4 and so on, so basically when I move from 1 to 4, it's going to be darker. But so in general, it's obvious that the ones are going to be the whitest, right? But which is the whitest of them all in general, or in other words, which has the highest value? It's B1. So you have B1, which is the whitest of them all. So B1 shade has the highest value. And of course, the 4s are the darkest, right? But which 4 out of A4, B4, C4, D4 is the darkest? It's C4, which is the darkest, or in other words, has the lowest value, right? So reddish brownish hue is basically A, right? Reddish brownish hue is A, B is reddish yellowish, C is gray, and D is reddish grayish. We talked about viscosity. It's the shear stress divided by the strain rate. So the answer is A, shear stress divided by strain rate, or the slope of the, in other words, the slope of the shear stress strain rate curve. Next important question, applied question, guys. Assertion and reason. Assertion is elastic modulus of a material is independent of its ductility. So first of all, let's look at this statement in greater detail. What exactly is the examiner trying to ask us? When I draw the stress versus strain curve, the stress can be, for example, tensile. Of course, it can be shear, it can be flexural, it can be compressive, etc. We have a straight line portion, right? We have some value of proportional limit here, and then of course the material is going to plastically deform up to the level of whatever it can, whatever its property, inherent property is, and that's ductility, right? And then ultimately the material is going to fracture at the ultimate stress or the ultimate strength value. Now the first assertion is, what is the assertion, guys? Elastic modulus of material is independent of its ductility. So what does this mean? First of all, what is the elastic modulus? Elastic modulus is the slope of the straight line portion of the stress strain curve. So basically, what I'm interested in when I talk of the stress strain curve is, okay, this portion, straight line portion, right? So the slope of the straight line portion is the modulus of elasticity, or the elastic modulus, or the Young's modulus. The story ends here. The story ends here. Why? Because beyond the proportional limit, there is no straight line portion, right? We have entered the zone of irreversible or plastic deformation, right? Which is basically a measure of ductility under a tensile load. So first of all, is this true? Is the assertion true? Elastic modulus of a material is independent of its ductility. Absolutely true, right? So that's my first here. Elastic modulus is measured in the linear region of the stress strain plot, right? Absolutely. So the one on this graph here, this thing which is highlighted with yellow, it represents the straight line portion, and the slope of this yellow thing is basically the elastic modulus. So this line, is this true? Elastic modulus is measured in the linear region of the stress strain plot. It's absolutely true. Is this related, or is this the correct reason as to why the elastic modulus of a material is independent of its ductility? Absolutely. Because I've got no business of what is happening beyond the yield strength, beyond the proportional limit. I can have, I'll tell you what, I can have another material which is having the exact slope, here of this material. So let's just look at another material. I'll draw another graph here. All right, guys. So let's draw another stress strain graph here. Exact slope, right? But this material is going to fracture very soon. So its ductility is very less as compared to the material on the right? That's the only, level of ductility or the plastic deformation. Here it is this much. But the slope is the same, right? The steepness of the curve is the same in the straight line portion. So it's the same. So it's independent of the ductility, right? Because we are measuring it in the straight line portion. So the second statement is true. That's, of course, another inference, and it is also the reason why the first statement is true, right? So the answer is both assertion and reason being correct, with the reason being the correct explanation of the assertion. So B is the answer here. Right? Next question, biological responses to substances in the human body can be. Now, this is a question which is taken from your chapter of biocompatibility of dental materials, guys. Now, of course, to any foreign body, we can have an inflammatory response. We can have an allergic response, yes. Can we have a toxic response? Yes. Can we have a mutagenic response? Yes. So all the four are correct. So D is the answer. Next question, contact dermatitis, friends. It's relating to the four types of hypersensitivity or allergic reactions that we study. So friends, type 1, if I talk of type 1, 2, 3 and 4, there's a similarity between 1, 2 and 3. They are immediate or onset is fast. Why? Because they are directly leading to the release of antibodies, right? So antibodies or immunoglobulins, right? Whereas the type 4 test, the type 4 reaction, allergic response, Jelen-Coombs classification type 4, is cell mediated. So it takes some time. So that's why it's synonymous with delayed. Hypersensitivity, right? And contact dermatitis is a type of type 4 reaction. So the answer here is type 4 hypersensitivity reaction. The most allergenic metal known. Next question. Again, completely memory based. The answer is nickel. Related MCQ. What is the incidence? What is the incidence of allergic reactions on exposure to nickel? It's as high as 10% to 20%. It's a very common component of artificial jewelry, and that's why its incidence is more common in females than males. Next question, the element which is protective against the toxic effects of mercury. The answer is selenium. Memory based, one has to memorize this. To check the biocompatibility of dental materials, all of the following are animal tests except. So this is from your biocompatibility of dental materials chapter. It's an applied question. The answer is Ames test, and basically Ames test is a laboratory test, not done on animals, neither animals nor humans. You take some agar plate, right, and you incubate bacteria with a growth medium like, for example, just for example, histidine. And then, of course, you check the increase in the cell population, checking for mutagenicity of a given material when these bacteria are exposed, right? So Ames test is a proper laboratory test, not done on live animals, right? Elements used as grain refiners. Very important concept, guys. First is the answer: iridium, rhenium, ruthenium. Iridium, rhenium, and ruthenium is the answer that you should go for. There's another confusing option here, which is iridium, rhodium, and rhenium. Guys, rhodium also can be used as a grain refiner, right? So it's not like iridium, rhenium, and ruthenium have got some exclusive, um, exclusive right over being called grain refiners. Even rhodium is a grain refiner, right? But a better answer is option A: iridium, ruthenium, and rhenium. Now, what exactly is a grain refiner and why do we need it? Guys, grain refiner, refine, basically it means that when the molten alloy is being cast, right, and when it is being cooled, then the cast structure, the ingot or the solid metal or alloy that you get following cooling, the size of grains or individual crystals of the metal or the alloy, if it's small and equiaxed, that is the same in all the XYZ directions as compared to a long dendrite like formation, that would be known as a fine grained alloy, right? Small means fine, right? Fine basically means small, and equiaxed, right? Now, in general, this is desirable in terms of strength, right? There is a relationship known as Hell-Pech relationship, which says that the yield strength, now yield strength is a measure of how strong the material is, right? The yield strength is inversely proportional to the square root of grain size. So basically, smaller is the grain size, better is the physical properties, right? So that's why one reason why we add these grain refiners in, say, for example, a gold alloy, casting gold alloy, is you would get a fine grained material. Now you'll ask me, sir, I mean, how do they do this? So basically, they've got extremely high melting points, almost 1900, 2000, right? So when you're melting the entire alloy, right, you're taking a temperature of where? Up to where? If you talk of casting gold alloys, you're taking that temperature of high noble, you're taking that temperature of maximum 600, 700 degrees Celsius, right? So these iridium, rhenium, ruthenium, which are present in very, very small quantities, they're not molten because they don't melt, because their melting point is much higher than the temperature you are subjecting the alloy to, right? So they act as nucleating agents. Basically, they act as small seeds, so they're applied, they put in very small quantity, right? So that they don't disrupt the melting process. So they act as nucleating agents, very small seeds which are already solid, and then they facilitate the fast, you can say the fast cooling of the molten alloy. And what happens when the cooling is fast? When the cooling is fast, guys, less time is there for grain growth to take place, right? So the process during which melting to cooling is taking place, when it becomes hastened, when it is fastened, when it takes place fast over a short period of time, the grains remain small, fine, equiaxed, right? And that helps in improving their properties, right? So that's the function of grain refiners. Next question, solution heat treatment, right? The solution heat treatment is basically a method to restore a type 3. So has to be memorized. Restore a type 3 and 4 casting gold alloy to its softened condition. Right? And how do you do that? You basically subject it to a temperature below the solidus temperature. What is the solidus? Roughly around, say, for example, for a gold alloy, again, I would say it would be 700 degrees Celsius, right? So just below the solidus temperature, you subject it to a heat treatment. It's basically a heat treatment, solution heat treatment, or soft hardening, also known as softening or soft hardening heat treatment, right? So you subject it to a temperature of below 700 degrees Celsius for about 10 minutes. That's one protocol, right? And then you quench it. Quenching means cool it rapidly, right? So this helps in um, creating a relatively soft uh, structure to the type 3 and type 4 gold alloys.